was estimated to be 64 million people in 2013, and this number is estimated to be 112 million in 2040. So that is increase about 70% تقريبا. In the Middle East, glaucoma was also found to be the second leading cause to the visual impairment. In Saudi Arabia, there is not too many studies that investigated the prevalence of glaucoma nationally. The most recent study was 22 years ago, which estimated the prevalence to be 5.7% of the people to have glaucoma. This means that if you see 100 patients in your clinic, you can expect 5 of them to have glaucoma. And this is a significant high number, because suppose you see about 100 patients in a week. That means you'll expect about 5 of these patients to have glaucoma in this week. In month, we'll have like 20 patients with a glaucoma, and this is a high number of these people. So we said it's a second leading cause, but it's the first and leading cause of the irreversible blindness or the visual impairment. Glaucoma becomes a public health concern because of that, and the disease affects the quality of life, activities such as driving and reading. And I just showed in the previous graph and previous slide that cataract is the leading cause, but cataract can be treated and cured by replacing the IOL and the intraocular lens, and the vision can be restored. In glaucoma case, the vision cannot be restored. What the patient has lost is lost. So we just try to preserve what is remaining of the vision, and that's the severity of the disease, or this is how the dangerous the disease is. So the mechanism of glaucoma is unknown, actually. The traditional thought about the glaucoma is in the primary angle closure glaucoma, where the IOP is high and then the exoplasmic flow will be affected. The blood perfusion is going to be low, the nerve fibers dysfunction or damaged or died, and then ganglion cells death will be happening, or what's called so-called apoptosis. So this is the automatic cell death. So there are several challenges around the glaucoma. So the mechanism is unknown. The lost vision cannot be restored. The treatment is just to preserve the remaining vision. We can call it just management. It's not actually treating. Because if we say treating, that means we restore the vision, and this is not the case in glaucoma. Some types of glaucoma cannot be easily diagnosed. Therefore, a significant amount of neural tissues are lost. And that have been said, there was a study indicated that 50% of patients did not know that they have glaucoma. So these patients will have a significant loss of the neural tissues when they go to the clinic. So this is why glaucoma is a public health concern in Saudi Arabia, especially because of 3 main reasons: the aging and diabetes. So the diabetes ratio is increased very dramatically in KSA. Also, the high blood pressure is increasing in recent years. If we talk about the age, the first risk factor, if you just focus on the green line here, this is for this represents the people who are 40 years or older. We can see the trend is going up, and that means the number of people who are older than 40 are increasing across the years. And this is from the General Authority of Statistics here in Saudi Arabia. And this is just the projection until 2019. We're looking forward to see the projection of the 2025, which will indicate more number of people who are older than 40. And we're talking about people who are older than 40 because a lot of studies show that the thickness of the RNFL, which is the neural tissues and which are also the fibers of ganglion cells, are getting thinner. So that means if these neurons are getting thinner, it means there is a shrink, and then the exoplasmic flow will be lower, and then the signal transferring of the visual signal is going to be also slower. And then that means also these fibers will be dysfunctioning, and that also means the ganglion cells will be affected in that way. On the other hand, the functional part of this, which is the visual field, is reducing with the age increases, and that means also that would affect the quality of life in terms of the functional performance for these people. Also, this is a graph from the General Authority for Statistics showing the highest percentages of the chronic diseases of people who are 65 years and older is the diabetes and blood pressures, which are, once again, the most important risk factors for having glaucoma. Now, when we look at the people who do the routine medical exam check, there are only 25% of the Saudi population who do the routine medical exam check, and this is another challenge. So you only have the access, or I mean, you can only expect, or you can also check for glaucoma, and only 25% for 15 years and older. For the 75 years and for the 75%, the remaining 75%, maybe it's hard to reach them out and do the routine or the comprehensive eye examination for them. So there are challenges in diagnosing the some types of glaucoma, such as the primary open-angle glaucoma and the normal tension glaucoma, because the IOP will be normal. And these types also are asymptomatic. For example, so to make the differentiation between the types of glaucoma, if we consider the primary angle closure glaucoma, they will have painful, they have redness, they will have other symptoms that indicate they have something in their eye going on in their eyes, and they will just go to the doctor office to get the check for their eyes. But for these people, for POAG and NTG, they will not feel it until they actually lost at least 30 to 50% of their neural tissues, and that's the challenge. As I mentioned, for the acute primary angle closure glaucoma, will usually come to the clinic with their symptoms, and the only thing that you can do with these people is just manage and monitor the progression, which is critical for their cases. And when we say manage and monitor the progression, that means you reduce the progression, so you just preserve what is remaining of the visual function. There are also several challenges in monitoring and managing the disease, and one of the most challenging issues is how quick the progression is. Also, sometimes the current testing methodology is not optimum to measure the progression in patients with glaucoma, and this is about the precision and the accuracy of the performance of these methods. So the goal is, it's hard to say stop. It just, we say reduce the progression, and still it's a challenge for glaucoma care. So if we talk about the action that we need, let's just, before we talk about the action that is needed, let's just summarize what we just talked about, which is we talked about the challenges. The mechanism is unknown, and as we know, if you know the mechanism of such a disease, you will know how to fight the disease, you'll know how to treat the cells and how to target them. The second point is the lost vision cannot be restored. So there is no treatment. There is no actual treatment. The treatment that whenever we say treatment in glaucoma is just managing the case. So it just reduces the progression or preserve the remaining vision. The treatment is to preserve the remaining vision. Sometimes cannot be easily diagnosed, as we mentioned before. And glaucoma is largely affects poor quality of life. And this is now a hot topic, and it has been shown in several studies that patients with glaucoma has a low quality of life in several aspects, such as driving, walking, mental health, social health, and so on. And also we talk about the risk factors, which are age, diabetes, and hypertension. So all these together make the challenge to fight the disease. So to get in the right track to fight the disease, first of all, we need to know and understand the epidemiology and statistic of the disease. So if we say, what's the prevalence of glaucoma in Saudi Arabia? There is no national study that looked at this prevalence, because if I know the prevalence, I would know how to fight the disease. I would know how many patients I would expect to come to my clinic, and then I will, based on that, I will make the plan to have more glaucoma specialists and more people or optometrists in the primary care to work on these patients. The second point is about the routine and comprehensive eye examination. This is essential for, especially for those types of glaucoma that are not symptomatic or asymptomatic, so that we can detect the disease in early stages. And to do that, we need to do the routine fundus exam, routine IOB measurements, evaluation of the anterior chamber to check the angle, and then we need to understand and evaluate the imaging assessment. It's not about just do the scan for the retinal layers and look at them and so see how they are and how they look like good or not. It just to understand what is the reduction means and how the reduction is progressing, and how some of the false positive, the machines that they make, we need to understand all these issues about the machines. Also, same thing for the visual field. It's not about just having 15 or 16 minutes with the patient in the visual field with the dark room and getting some nap or sleep with the patients. No, it's just about how to interpret the visual field printouts and the outcomes of the visual field. All these will lead to an accurate diagnosis and management. And if you see, this slide is without a title. If I ask one question about what do you think an appropriate title should be for this slide, what do you, I mean, give me just a suggestion. Any thoughts about a good title for this slide? You can write anything in the chat or something. The prevention, that's a very nice one. Any other thoughts? Okay. That's early detection is also good. Challenging roles of, okay. Actually, the first suggestion is kind of like very close to what I have. So it's prevention. And if you also look at all these procedures, especially the second point, which is the routine and comprehensive eye exam, you would think these are the procedures that can be done in the primary eye healthcare. And these all can be done by optometrists as a first line of protecting and preventing preventing or helping in early detection of glaucoma. And now, and if you look at the procedures we just mentioned before, it's about the definition of glaucoma that I mentioned in the first slide. So we talked about the fundus exam, we talked about the assessment of the visual field, and we also talked about the imaging assessment. And all these components are included in the definition of glaucoma. So if you're good on these procedures, that means you're getting to the point of getting an accurate and precise glaucoma diagnosis. And still, there are challenges. So it's not, this is just theoretical explanation of how the diagnosis should be, but there is a lot of challenges in the clinic, in the actual clinic, about the diagnosis of glaucoma. So as we mentioned, early diagnosis is crucial, and it's about the prevention of having advanced or moderate or advanced cases. It has been suggested that early diagnosis is critical to reduce the progression of the disease that was mentioned in Heal et al. And also the early detection will help how aggressive the treatment plan should be for the patients. For example, if you use the eye drops, or if you use the surgery, which option should choose in terms of the treatment, and that's going to be depending mainly on the diagnosis. And also the accurate diagnosis will help in monitoring and managing the progression based on the baseline. This is just the table from the study that I mentioned. And if you look at the progression here, sorry, go back. The progression, the number between the parentheses is the percentages. So this is the 45% and then 62%. The treatment control, when you put some treatment and you monitor the progression, we have only 45% of the progression, while the people without treatment, they have 62% of the progression. Also, the cost effectiveness of the glaucoma care is about to is also affected by the early detection and prevention of glaucoma. So if we look at the cost for each stages, here's the stage 0, 1, and 2. These are about the mild stages, I would say. And then stage 3 is the moderate stage. Stage 4 is the advanced stage. And we can see the price for each stage here. And also we can look at the light boxes on the top here, which is office visits, other services, and visual field test. If you look at the bars, these light boxes are the cheapest ones. And from the cheapest ones, you can look at the glaucoma in early stages and reduce the cost for each. So from stage 2, this is 1,765, and it can go up to 2,464. That's about increase about like 30 to 40%. And also one more thing, if the patients if the disease was detected in late stages, that means they will go to the low vision stages, which is going to be also highly cost, and it also will be affecting the social and quality of life of patients. So the question now is how to make this prevention plan. As we mentioned, the early diagnosis in primary healthcare is a key to make this prevention. And as I said before, the prevention is the key in glaucoma case, because till now, there is no treatment that restore vision that was lost due to glaucoma. So prevention and early detection are the keys to deal or fight the disease. Now, if we look at these all procedures from routine fundus exam, the IOV measurements, and the anterior chamber, and so on, these all can be done by optometrists, and the OD right now are well trained during their study and during their rotations to do all these examination. Once you've done, or once you have skills to do all these examinations, there is high possibility to have effective treatment that will be based on your accurate diagnosis. And this is actually the role of optometrists on how to deal and fight glaucoma. And so I'm now switching to some challenges on how to deal with glaucoma, or on the slide that says how. So the clinical challenges exist on assessing the cup disc ratio. This needs a lot of training and focusing during the exam itself. Also, drainage hemorrhages also need to be carefully diagnosed and could be missed. And this is very common in normal tissue glaucoma. This can be easily missed, but when the optometrist is really trained on these, they can catch it in early stages, and that will help a lot, because as we mentioned before, normal tissue glaucoma cannot be just like the traditional one. The IOP will just be low, or normal tissue glaucoma will be low and will be in the normal range. So as we mentioned before, some types also of glaucoma is asymptomatic. That's very challenging. Here are some signs that you can use to look at the disc or other examinations, and can lead you to kind of like do a good diagnosis. I'm not gonna say accurate diagnosis, because there's still so much work in terms of research to reach to better diagnosis methodologies for glaucoma. So the optic disc appearance will be like pale, the cup disc asymmetry, trans hemorrhages, rim thinning, iron field thickness thinning, visual field defects, and narrow angle. And there's a very important piece of knowledge about these. So if you only see trans hemorrhage, it does not mean that patient have glaucoma. It has to have also visual field that is associated with the defect that you see in the disc. The same thing for iron film thickness thinning alone is not a sign to say this is a glaucoma, or to decide this is a glaucoma diagnosis. It's actually has to accompany it with visual field defect or something in the disc, like cup disc asymmetry or something. So it has to be 2 or 3 signs together, and as according to the definition, 2 signs should be structural and 1 function from the visual field together will make the diagnosis of glaucoma. So it's not actually 1 part and then you just rely on it and then go ahead and do the diagnosis. It's also it's about like 3 or 4 signs that you need to rely on, including functional defects. And this is how hard to or one of the challenges in glaucoma diagnosis. This is just some of the instruments that should be used. And here I'm just going through very quickly. I don't want to use the significant amount of time, but the disc should be looked at. I mean, the rim should be looked at, and the evaluation of the cup disc ratio should be done. This is just a schematic of how to look at the cupping and the disc. And this is the actual disc that you should look at. Then if you look at the 0.9, you can see the cupping here, and the whole disc is pale, and you can see the difference in 0.7, 0.5. The paleness of the disc is about like 50% of the disc. It's the whole disc. The other thing is also, if you do the fundus photograph, the red-free fundus photograph, you can see the dark band, which indicates the defect of the RNFL. Sometimes it's very hard to get. So if you look at the superior temporal of the disc, there is a very little or subtle defect of the RNFL. It's like a very small dark band there. I'm just here showing some other instruments that could be used to look at the, here's something called HRT, and that look at the REM area, and it gives you the evaluation of the how thin or thick the REM is. Here's a bigger one for it, and when you see X here, this is a thinning. Here's another instrument, which is the OCT. You can look at the thickness of the RNFL. Here's just a comparison between the cross-sectional or B scan of the OCT with the histology layers of the retinal layers. Another technique which looks at the GCL, the ganglion cell layer, and how is that effective in terms of determining the thickness of the ganglion cells layer. Another technique of looking at the lamina cryptosa and how to look at it and how to evaluate it. The second part of the definition, if you all remember, is the visual field interpretation or the visual field changes. This is the regular printout of the visual field. And I know the visual field is kind of like not likable by most of the people, but it's very crucial and important in glaucoma diagnosis. And it gives you very, very critical information about the cases that we look at. And I'm going to show you some just hints to kind of like show how important the visual field is. And unfortunately, not too many people are able to look carefully at the numbers and the charts and the some of the parameters of the visual field that can indicate a defect or glaucomatous defect. This can be found in the internet. It gives you every single part of the printout, and you can read about them. So the patient information, and I'm going to, I think, yeah, there's a larger picture for it. So if you look at the fixation losses, you need to have them less than 3 or 4. More than that, it will be considered as unreliable test. Same thing for the false negative and false positive rates or errors. They should be less than 20%. And if they are higher than 20%, that means it's an unreliable test, and you need to repeat the test. And these are just giving you the type of the testing and the background and the type of stimulus that have been used. And then 24-2 is the type of the test that you use for the visual field. And now this is the second part of the printout. If we can see here, there is among these numbers, there is 0 here, which means this indicates the blind spot where there is no sensitivity at all. And then this is the grayscale representing the numbers here. So when you see high numbers here, like 33 and 32, this is very white. And as you go to the periphery, the sensitivity goes down, and then you have grayish or less white, let's say, in the grayscale. And this is normal, getting to the periphery, getting a lower sensitivity. However, if you look at these 2 points here, 27 and 27, question mark should kind of like getting to your mind, saying, why is this lower sensitivity? Also, this is 31 and 30. And if we look carefully to the total deviation and pattern deviation, you can see these 2 points here, which is the black box here. We called it black cluster. And it indicates less than 0.5%, which is a significant a significant defect, visual field defect. And there are also other criteria for that, to say is it defect or not, by saying like at least you have to have two clusters next to each other so that you can indicate this is a defect or not. So in this case, it's not defect. You have to have 2 or 3 adjacent locations with less than 0.5%. And also MD means here, if you look at this on the right side, MD means mean deviation. In this case, it's plus 0.24, but sometimes it would go like -3, -4, and deeper, like -12 and -14. And this means the mean deviation is they take every single location and then they subtract it from the normal normal values that is built in the machine, and then they will have the mean deviation for all locations, and this is about 56 locations. Also, you need to focus on this line, which is the fixation line down there, and that indicates how the fixation of the patient was. And then if you have like high spikes going up and down, that means the fixation of the patient is not good, and that also indicates unreliability test, visual field test. There's a question about the PSD. This is the patent standard deviation, and there is a calculation for this. And I do not see many people using it because it's can be in normal and patients. You can have the same number though. But general thoughts about that, if you have it high, like plus 6 or 7 or something, that indicates some defects in the pattern deviation map. And here I'm showing an example of the progression in the visual field for a case. So we can see here it's almost clean, but we still have some 2 points in the pattern deviation. And then for the next visit, we have this inferior defect, inferior peripheral defect. And then we have this defect extended to the whole inferior part of the visual field. And then it's also extended in the superior visual field. Be careful for some cases when you see the grayscale scale is kind of like clean. However, if you look at the pattern deviation and total deviation carefully, you see a lot of clusters that are 0.5, less than 0.5, which is significant defect. In this case, it wasn't shown in the grayscale. And we can see also the MD here, it's -4, which means it can be considered like mild to moderate visual field defect. Here I'm just showing several types of the visual field defects due to glaucoma. So nasal defect or percentral defects, and we have altitudinal defect, temporal wedge defect, arcuate defect, and in advanced cases you have global loss. This table just shows the staging based on the DBs or the visual field defect. In this slide, I show differential diagnosis. So be careful to when you test visual field. It doesn't have to be glaucoma. It could be something else like other neural diseases or neural cases. Generally speaking, the glaucoma defect will respect the horizontal line. So except in the advanced cases where there is a global loss. So we see here left homonymous heminopia due to stroke in this case, and then here's a case for pituitary tumor where the bitemporal heminopia is present. So to summarize, glaucoma is a public health concern. It's hard to diagnose and manage. It's challenging to detect the disease in early stages. It affects the quality of life, the prevention, and the primary healthcare, which is the main role of optometrists. It could be done with the routine check, training and new developments in accurate diagnosis and management. So the future plan that could be getting skills and skillful optometrist on how to do the ONH, the optic nerve head diagnosis, RNFL diagnosis, and visual field diagnosis, which all together will make glaucoma diagnosis. And in this case, we will be able to do the early detection of glaucoma. And also, if you refer them to glaucoma specialist, they will have a really nice and accurate diagnosis that will help them on management and treating if there is treatment of the disease. Also, the glaucoma screening is very important for patients who just come to the clinic. The lost cost effectiveness treatment plan is also important. It's also very critical to improve the quality of life of these patients by also early detection and not having too much of the neural losses. Also, we need to reduce the effect of complications like psychological and social and economical effects on the patients. Thank you for your listening, and I'm ready for questions or discussion points.
يعطيك العافية دكتور محمد، والله يكتب أجرك على هالمعلومات القيمة والتي تضفي الكثير لكل مختص في رعاية العين أو البصريات عموما. نستقبل أسئلتكم في الشات، أو اللي يبي ياخذ المايك بس يرفع يده ونعطيه المايك.
السلام ورحمة الله وبركاته. مساء الخير. في البداية مبارك لكم بالشهر الكريم، وصلى الله سبحانه وتعالى يوفقنا وإياكم للصيام والقيام. أنا صراحة باسم الجمعية أو باسم اللجنة العلمية أحب أشكر الدكتور محمد اللويمي على هذا الإثراء. محاضرة قيمة وجميلة جدا، صراحة يجعلنا نطرق أبواب أخرى كانت مغلقة أو كنا نخاف منها يعني ممارسين للبصريات. لكن اليوم يعني الدكتور محمد خلينا نقول نفتح عيوننا شوي على مجال ممكن نطرقه ويعني نبدع في يعني جلوكوما مانجمنت. شكرا دكتور محمد. الشكر. أنا أيضا يعني ما أنسى أشكر شركائنا في هذه الفعالية، نادي دكتور بصريات، والشكر أيضا للدكتور محمد الحربي. أنا فقط حبيت أشكر يعني وأترك المجال للأسئلة. شكرا لكم.
يعطيك العافية دكتور ماجد. I think there is a question about if we don't have a visual field machine normally, which tests we can do for glaucoma field test. There is a manual visual field test, which is can be done in the tangent screen, or very simple way to just do the to see the isopter of the visual field. And this is something can be done. It's not accurate as with the with the machine, but it can be something. Something can be done in patients with glaucoma. Also, if there is a very careful evaluation of the optic disc, that can be helpful also. And if it's suspicious or something, can be the patient can be referred to the nearest hospital that they have visual field. Another question, which is how do optometrists help patients with glaucoma? It's in different aspects, as I mentioned in the lecture. So if you're talking about patients who were already diagnosed with glaucoma, that means the progression نفسه أو management للdisease by monitoring the visual field progression, by monitoring the iron field progression, by monitoring the REM tissues progression. All these together should be monitored, and if they come to the clinic again, these parameters have to be seen. There is a question also about how common to have glaucoma in patients under 40 years old. That's a good question for Saudi Arabia, actually, population, because we have done a study in Saudi Arabia, and we saw people who are under 40, like in 30s, who had glaucoma, and there is no information about the epidemiology or statistics for this type of population, but that's a good question that can be investigated. القطرات مستخدمة في تطويل الرموش، لكن في دكتورة نهى في قطرات كثيرة، حتى في قطرات تستخدم لجفاف العين، فيها مركبات كيميائية، يعني اكتشف فيما لاحقا يعني في الأبحاث أنها تسبب ارتفاع ضغط العين. فإلى الآن في كونفليكت في إنه نستخدمها لعلاج بعض الحالات وتسبب ارتفاع ضغط العين، وفي نفس الوقت القطرات اللي بتستخدم لتخفيض ضغط العين تسبب جفاف للعين. فإلى الآن هذه نيو هات توبيك، فيها investigations كثيرة وفيها أبحاث كثيرة وداخلة فيها الكومبانيز حقت الدروبز أو الميديكيشنز بشكل كبير. وإلى الآن يعني مرة نشوف بيبر تقول لك إنه الألفاجان وغيرها اللي تستخدم للريديوس الاي او بي تسبب ضغط، تسبب جفاف، والعكس صحيح. بعض القطرات اللي تستخدم لعلاج جفاف العين تسبب ارتفاع ضغط العين، ومنها قطرات تطوير الرموش كذلك. فبس تعقيب بسيط على سؤال الدكتورة نهى، اللي يستخدم أحد هذه القطرات لازم بشكل دوري، يعني كل 3 شهور يشوف ضغط العين ويشيك على كل البارامترز الخاصة في الجلوكوما. Is it allowable for OD to prescribe drops for؟ لا، هنا في السعودية لا. When to determine if the management is drops or surgery? This is the question that goes to the glaucoma specialist. If you have done your part in terms of the diagnosis and management, glaucoma specialist is not only ophthalmologist, glaucoma specialist has to make that decision, and it's going to be largely depends on your diagnosis. How common shallow AC could develop glaucoma? I think it's very common, because once you have shallow AC, anterior chamber, you'll have high IOP. That's the logic. I mean, it's that's the normal cases, but there are cases which is shallow anterior chamber but does not have high IOPs, but they are still in the risk of having glaucoma. What's the best of taking the IOP is the Goldman. That's the gold standard. Goldman IOP measurements is the gold standard. glaucoma effect on macular region, can discuss. So the traditional thought is we will, in advanced cases, we will have the tunnel vision where the macula will not be affected so much, but more research and more hot topics now is indicating that macula could be affected in early stages of glaucoma, and this is why we need to use the 10-2, which is only testing the macula in patients with a glaucoma, even though they are in early stages. But this is still argumental topic in clinical part, because if you want to use 10-2, how about the periphery regions using 10-2? And then the question is, are you going to use the 10-2 and 24-2 both in the same visit? That's going to be too much for the patients, and then they will be tired, and then there will be issue of the reliability of the visual field testing. So this is a lot of discussion, and we can have like a whole lecture or a whole discussion part about it. I do not understand most reliable equipment. There are different companies, and I mean, it's not our role to say which company is the best, but there are different of them there. دكتور أنوها تقول نعم أرجو نوعية لأنها كثير منتشرة من دور خسارة التوعية. إذا تقصدين القطرات أو شيء، فهي طبعا لازم تكون تحت وصفتها البريسكريبشن معروفة. قطرات لازم ضروري أنها تكون سواء الجفاف أو الجلوكوما، أو لازم تكون من تحت الطبيب، يعني من وصفة الطبيب. Is the link for next webinar? Okay, this is for you, Dr. Majid or Dr. Muhammed Al-Harbi. I hope I got all questions, and if I'm not, please ask me. Okay. وانا I agree معك يا دكتور نهى انه اخصائي البصريات لازم لما يشوفوا مرضى الجلوكوما يكون عندهم التوعية الكاملة، او حتى الناس اللي يستخدمون قطرات اخرى زي ما تفضلتي، قطرة تطويل الرموش او قطرات الجفاف او غيرها، انهم يشيكون على. ضروري جدا موضوع التوعية في هذه النقطة هذه، وفي نقاط اخرى كثيرة بما يخص مرضى الجلوكوما. مهم جدا انه دور اخصائي او دكتور بصريات ما يتوقف على انه دايجنوزس وخلاص، او انه يسوي له بروسيجر معين وخلاص. لا، لازم يكون في توعية بكافة الاسبكتس للبيشنتس. I think that's all.
في عندنا بس الأخ محمد تركي عندك مداخلة، تفضل.
تفضل.
السلام عليكم.
السلام ورحمة الله وبركاته.
Thank you very much, Dr. Muhammed, for the informative presentation. I find it very nice. I want to add something regarding the role of optometry in the progression of detecting of the progression of glaucoma and congenital glaucoma. As we know that the children, especially the pre-verbal children, we can't do visual field to monitor the visual field progression, and the optic nerve changes. It might be reversed even if the disease is already available and progressing, because there is elasticity of the optic nerve. So the most important thing during the congenital glaucoma progression management or monitoring is the myopia progression. If we find that myopia is progressing more than what is we think it's usual in the age, we know the natural history of natural pathway of the myopia is progressing, but in certain degree. If it's progressing more than this degree, we think about that there is progression of the congenital glaucoma, and we think to manage to control it. So if you allow me, this is the only point. I think it's very important, even with to help, the optometrist help us as a glaucoma specialist in it. Thank you very much.
Great addition. Thank you very much, Dr. Muhammed. That's a very important issue also for optometrists, especially if we know there was a recent publication by Kaikish Group on the number of congenital glaucoma, which is going up very fast. And that means we need more optometrists to be trained on how to look at these the patients and how to look at the important parameters such as the myopia progression with these cases and the cutoff of any of the myopia measurements for these. Thank you very much, Dr. Muhammed Turki. It's a great addition.
شكرا لك دكتور محمد.
نعم. في سؤال لو سمحت لي دكتور محمد الحربي بخصوص يقول how hypertension disease can be risk factor for glaucoma. So maybe Muhammad Turki will add to this as well, but the hypertension is a very important risk factor for glaucoma patients in terms of there's somehow relation between the IOP and hypertension. And also the hypertension will affect the blood flow, and the blood flow can also affect the retinal nerve fiber layer, since they are the main nutrition source of the RNFL. So this is sometime how they can affect the or they can cause can be risk factor for glaucoma.
Yes, Doctor. Regarding the hypertension and glaucoma, there is a lot of studies say that the hypertension is causing or progressing the glaucoma, but it's not. In some studies said to every 20 millimeter mercury of raising of the blood pressure equal 1 millimeter mercury of IOP. So it's not that significant relationship. Actually, the hypotension, the low blood pressure, is affecting more the glaucoma and causing, as you said in the presentation or the lecture, is one of the most common factors, the risk factors of normal tension glaucoma. So hypotension, low blood pressure is more common and affecting and causing glaucoma more than hypertension.
And TG, yes. Thank you, Dr. Muhammed.
Thank you.
في أي استفسار أو أي مداخلة قبل ما نختم؟
إذا ما في أي استفسار أنا أحب أشكر الجميع حقيقة على مشاركتهم ومداخلاتهم، وقبلها الشكر طبعا للزملاء في اللجنة العلمية في جمعية البصريات السعودية، وأتمنى لكم الجميع التوفيق، وقبل الله منا ومنكم يا رب العالمين.
الله يعطيك العافية دكتور محمد، شاكرين لك، أثريتنا صراحة في الموضوع المهم. شكرا لكم جميعا على حضوركم. شكرا لزملائي في نادي دكتور بصريات. نلتقي بكم غدا إن شاء الله على خير الساعة 11 مع الدكتور مساعد الحسن في موضوع آخر. ونشوفكم على خير.
شكرا للجميع.